There we go. If I save it to my computer, it starts bogging down my Zoom, so I'll save it to the cloud this time. All right. So welcome everyone, and thank you for joining us today for the City of Patterson, Ryan White HIV/AIDS Program, Clinical Quality Management Committee. And thank you, Angelica, for pointing out that today is the 11th and not the 10th. So today is October the 11th. We appreciate everyone joining us today for this committee meeting. So just really briefly, we'll take a look at our agenda before we begin. We'll do a roll call and a call to order, a moment of silence, welcome and introductions, reporter updates from the recipient's office, subrecipient reports on the Care Continuum dashboard, quality improvement project updates, subrecipient monitoring updates, data presentation, and we did send that out yesterday for everybody to take a quick look at. And then we'll also talk about a upcoming training opportunity on E2 for providers and subrecipients. And now I will share this part of the agenda. So you can see that as well. I did make the change to October the 11th. This will give you a couple more details of what we'll be looking at throughout the day today during this meeting. And now we will just recognize a moment of silence for those who are in the battle against HIV. All right, thank you. All right, so we'll do quick introductions and a roll call. First, we'll start out with our subrecipient team, and we'll simply utilize this to go across the board to see who is with us today and who is not with us today. Oops, and it doesn't like me. Try again. I like this and copy it. All right, Bergen Family Center. Is Paula with us, or a representative from Bergen Family? All right, Buddies of New Jersey. Anybody from Buddies of New Jersey?
Hi, it's Carolina, non-medical case manager.
Good morning, Carolina. Thank you for
How are
joining
you?
us. I'm
Thank
well.
you.
Glad you made it back safely. All right, Capco, Tisa, Jerry. Anybody from Capco?
Good morning, everyone. Jerry Dillard from Capco Resource Center. Hope everyone is well.
Thank you, Jerry. All right. Passaic Alliance.
And good morning, Luz Rodriguez, case
Miriam
management
Torres.
and Darlene. And
Michael
Darlene
Rivera.
Sweeper.
Michael
All
Rivera.
right. All right, great. So we have Michael, Luz. I heard Miriam. And
Yes.
Darlene, is that correct?
Darlene Sweeper.
Yes.
Awesome.
Yes.
Great. Thank you all for joining us this morning. All right, Hackensack Medical Center. Miss Donna, you may be on mute.
Here we are, Donna and Irene.
Good morning, ladies. Thank you for joining us. Hyacinth AIDS Foundation. Anybody from Hyacinth? Northeast New Jersey Legal. I see Miss Mallory.
Yes. Hi, everyone. Mallory Ware. I'm the development manager at Northeast New Jersey Legal Services.
Good morning. Thank you for joining us.
Of course.
Any colleagues with you today?
No, just myself.
Okay, great. And from Patterson Counseling, I see a couple of people. Who would like to start?
Blanca, administrative assistant from Patterson Counseling.
Good morning, Blanca.
Morning.
Alicia Blakeney, Ryan White nurse and case manager.
Good morning, Alicia. And Miss Karen, I think you're on mute.
I was.
There you are.
Karen Walker, Patterson Director of HIV Services at PCC.
All right, thank you. And I see in the chat, I do not want to mess up her first name, Miss Baroni, the LPC from Patterson Counseling as well. So thank you for joining us.
Thomas, I'm here as well. Jochebed from Hyacinth. I could get myself off of mute.
No worries. Thank you, Jochebed. I appreciate you being with us today. Anybody from Patterson Department of Health? All right, Payne. I think I saw Roger.
Roger Lester, Executive Director, CEO of King.
Great, thank you for joining us. And Mr. Jerry?
Jerry Dillard, Chief Operating Officer at Payne.
Great, thank you for joining us. Anyone from St. Joseph's? Let's see, Anna. All right. St. Mary's General Hospital.
Hi, this is Jeanette, the secretary from the clinics. Priscilla is trying to connect into the website, so
Okay.
she'll be with us in a few.
Okay, great. Thank you for joining us. Straight and Narrow. See Miss Gloria.
Good morning, Gloria Price, medical case manager at Straight and Narrow Apartment.
All right, good morning. And Miss Connie.
Good morning, my name is Connie. I'm the substance abuse counselor intern here at Straight and Narrow.
All right. And anybody from Team Management 2000? All right. Let me circle back really quickly. I saw Miss Tisa come in. Miss Tisa, would you like to introduce yourself?
Good morning, each and every one of you. Sorry for beginning on late. Tisa from CAPCO Resource Center in Patterson, medical case manager, as well as I oversee the Hopper program.
All right. Thank you. And I'll do a quick introduction of my team from Collaborative
Excuse
Research.
me, Thomas.
Yes,
I
ma'am.
just want to say that the name that you were afraid to murder is Kiara.
Kiara, that was not where I was going with that. So I'm glad I didn't do it. Thank you, Kiara. All right,
Hey,
thank
Thomas,
you.
Kiara, our mental health clinician.
Great, thank you, Miss Karen. Good
Hey,
morning,
Thomas,
Priscilla.
this is Priscilla. How are you? I'm sorry. They don't like Zoom here. We use Microsoft Teams.
I know,
Because of
I know.
security
Thank you.
issues, so I had
So
to
sorry.
log back on a few times, so sorry.
Okay. No worries. I'm glad you could make it. Thank you, Priscilla. All right, and so I'm Thomas Rodriguez Shucker with Collaborative Research. We are the consulting group for the clinical quality management. I have with me two colleagues, Derek.
I'm Derek Jackson, also with Collaborative Research.
And Michael.
Michael Cran, also with Collaborative Research.
All right, and I see we also have some representation from RDE this morning. Michael?
Hi, nice to meet everyone. I'm Michael from RDE.
Awesome, great. And are there any other people that I may have missed that joined our meeting today?
My name is Angelica Boatwright. I'm the vice chair of Bergen Passaic Planning Council.
Great, thank you, Angelica. Thank you for joining us. All right, so we'll roll right back into the agenda. The only report and update that we have from the recipient's office is that we are pleased to announce that the subrecipient monitoring for chart reviews has been completed. So we want to thank you all for your assistance and hosting us and reviewing charts for all of the funded service categories. Those subrecipients who are present, please keep in mind that your fiscal and universal monitoring requirements and compliance documents should be uploaded to the FTP site no later than Friday, October the 21st. So please make sure that you have those fiscal and universal documents uploaded in alignment with those monitoring tools. All right, next we will talk about subrecipients care continuum dashboards. I hope that all of you were able to run your care continuum. And so again, we'll hop back to this screen and start with Buddies. Caroline, were you able to run your care continuum dashboard prior to today's meeting out of eCompass? You may be on mute. All right, we'll come back. Capco, Miss Tisa.
Yes, good morning once again. You know I'm not too savvy with that dashboard, but when I did go on this morning, I seen that our percentage rate did go up.
Okay, that's a good news.
Yeah, it went from 73 to 78. What I don't know how it's not a problem. My situation is that like when I click on the red number, you know, and I go to the individuals that's stating that it's missing things, but when I click on that individual, when it says view, and I go to the client and E2, and I click on their medical, they have the medical information for 2021 and 2022. So that somewhat creates a little disturbance in me because they have the information in Q2, then why it's not being registered properly.
Okay, and thank you, Ms. Tisa, because we definitely want to hear about that. So if you would please just take that E2 identifier, that if you start noticing those, that you're clicking on that red tab and you start noticing that those clients, excuse me, are in fact have medical outcomes, please email myself and so that we can work with RDE to figure out, where the definition may be correct in their system or we need to redefine something. So really quickly, if you don't mind, I'm going to share what Tisa's talking about. And this is what we're encouraging everyone to please do when you sign in and do your care continuum dashboard on a regular basis. Your care continuum dashboard may be in a different place. So please go to wherever your care continuum dashboard is. Ms. Tisa, do you mind if I pick on Capco today and run your report?
Pick, darling, I have to be, look, pick on me. I love it. I love it.
All righty. Thank you. And so you would pick MAI and Ryan White. And we're just going to make it easy. I'm just going to run it for August. We're going to run the report. And then it will bring back your care continuum dashboard. And what we're encouraging excuse me, what we're encouraging everyone to do is click on the red numbers. The red numbers means that some type of data is missing. And so if you click on that, it will give you a identifier report above, and then please look at those identifiers and try to update as much of that information as possible to get this number to 100%, to get all these numbers to 100%, right? That's eventually what we want to do. Viral suppression will really be dependent upon what their viral suppression rate is. So, our goal is to get everybody to viral suppression. So please, again, when you click on these numbers, it will give you a list like you see below of identifiers who are not meeting that requirement for that particular care dashboard. And this is what we're encouraging everybody to do their PDSA or quality improvement cycles around to increase our data efficiencies in the system. Thank you, Miss. Yes, ma'am.
Can you go back up to the top?
Yes,
Because
ma'am.
right here, that page right here, first page. Because when I went in, funding source, I did only Ryan White Part A. I didn't do MAI.
Yes, ma'am. You definitely want to include your MAI. It takes both of those parts to get a clear look at what your system would look like. Yes.
Right. Because since I didn't put MAI in, when I look down here on page 2, it's still 86%, but at 83, I mean, it's 78%. Go up a little bit, please. Up, yay. Right. And so when it came to the totals, this total is 83%.
Right. And keep in mind that I only ran it for just August.
Okay.
Yeah. And so what we're asking, make sure that you're running it for the entire grant year when you do it. So remember that the grant year starts in 2022 and then do it to the current date. So this might be a little different today, Tisa.
Yes, it's all right.
Let's see what it looks like.
Yeah, I want to see too.
So there you go, 78%.
Right, that's
what includes the MAI. Yep.
Right, and now it says 78%, even when I clicked on the 32%, if you click on it for a moment right there, okay.
It gives the list.
Right, these, right. And when I was going through these, just like if you go to LKF 479301, and it's permission to view, or I says view on my system, when I get that individual has 2021 and 2022 in their medical piece, CD4 counts and viral load.
Yes, ma'am. So if you could do us a favor and let us know which of these that you do have that information for that's in there that you're seeing. So, and let us know so that we can reach out to RDE and figure out what's going on there.
I most certainly shall, young man. Thank you.
And that goes for all subrecipients, please. If you see some discrepancies in your care continuum dashboard, please let us know because we are trying to iron out all of the glitches in that particular item. So thank you, Ms. Tisa. I appreciate you sharing.
Thank you, Thomas, for being so kind and humble with me this morning.
Of course, all the time. Yes, ma'am.
Oh, I just love your humble servant.
All right. Passaic Alliance, did you all have an opportunity to run your care continuum dashboard?
Yes, we did. And actually it went up from 62 to 72. We're still working on the red numbers.
Okay, awesome, great. That's, I mean, that's a great increase. Ms. Teets had 5%, y'all had 10%. So again, I think these are some low-hanging fruit that we can make some immediate changes with and some immediate, quality improvement projects to help align those. So great job, thank you. Miss Donna, Miss Irene? You probably on mute. Did y'all, Miss Donna, Miss Irene, were you able to run your care continuum dashboard?
Yes, I'm sorry. Yeah, we were.
This is the one I just read.
This is the thing, when we were having a little problem with printing out the dashboard. So I
Okay.
went into August and literally went through every single patient, and every single patient was virally suppressed.
Oh,
Except
awesome.
on our dashboard, it doesn't say that. It says 90%. But I did that
Okay.
this morning. I went through all 17 patients that we saw.
Okay, if you're able, if you could do us a huge favor and look at that report and see where those, again, like Tisa, where those,
Yeah, there
where
seems to
those,
be 3 missing. So anyway, I'll
okay,
just for your knowledge. But then what happened in September, unfortunately, is we went down to 83% because we had 4 new patients and they were
Okay.
all not virally suppressed.
Yep, that makes sense. Yes, ma'am.
Okay.
Okay, perfect. And the whole goal of this is for people to be cognizant of what's happening. And that's a great observation, that the reason that your viral load suppression rate went down is because you have 4 newly diagnosed or 4 new patients who are not virally suppressed. So
Right.
that helps out with observations as well. So great job. Thank you, Miss Donna, Miss
No
Irene.
problem. Thank you.
All right, Jochebed, Hyacinth, were you able to run your care continuum dashboard for today?
Yes, I was able to run our care continuum dashboard. What we've noticed is that we definitely have some missing information that's affecting, for example, the number of clients retained in care. We were at 39%, and that's not accurate. So we're going back to just put in the information that's missing to get a more accurate number.
Awesome. Great job. Thank you so much. Again, I can't stress enough of how this can be a really, really easy quality improvement project. So, once we finish this, I say this semester like I'm in college, once we finish this round of PDSAs in February, this would be a great opportunity for you to identify the whole data project of just looking at the care continuum dashboard and putting something in place to update that on a regular basis and to review that. All right, great. Thank you, Jochebed. All right, Miss Mallory from Northeast New Jersey Legal. And this is probably way outside of you, your line of work, and a little new to you as well. So we appreciate you joining us in the CQM projects.
Yeah, of course. Thank you. So unfortunately, our number is treading downwards again. We did have 3 new clients between now and when I last ran the report, which was last month.
Okay.
And we are missing information, but we are working on reaching out to the medical providers, reaching out to the case managers just to fill in the blanks, basically. We do have a system in place now, and also preparing for our monitoring visit was also kind of a push to get us going in some of the missing info. So hopefully for the next report, we'll be able to report some higher numbers.
Awesome. That sounds good. Thank you. We appreciate all the hard work you're doing. And just to throw out there that a majority of our clients are not seen medically by Ryan White providers. There's tons of outside sources. So almost 60 to 70% of clients in the Ryan White system are seen by a private medical facility. So that is a very heavy lift in doing, a release of information form to get those laboratories back and get those inputted. So we totally get it. We know it's going to be, this isn't something we can fix in a month, right? So we know this is an ongoing project, and we do appreciate everybody's participation in that. So thank you. All right, Patterson Counseling. I think you muted us and unmuted us all in one button.
Right. Can you hear me?
Yes, there you go.
Okay. So in August, we started out at 76%. And for September and October, we're at 79%. So we're holding steady. We're adding in missing information. I seen today, once you click the red in parentheses that you can see what you're missing. I didn't know that. So I'll be updating that stuff shortly.
Awesome. Great. All right. Thank you. All right. Roger from Payne. How about you, sir?
For the month of September, we're at 40%.
Okay. Is that up or down from your previous month, sir?
Up.
Okay, good. Good. And keep in mind that, you know, you do a lot of outreach and EIS work, and those people are typically not linked to care. So your viral suppression rate might be a little lower. But nonetheless, I know that your main goal is to get people linked to care. So we appreciate all the hard work you're doing. Thank you. All right, Miss Anna. I see that you're probably only in the chat. I did see you join us earlier. Okay, no worries. We'll come back to you. I know St. Joseph does a lot of other reports as well internally in tracking the outcomes of those. So thank you for all the hard work you're doing as well. St. Mary's.
Hey, hi, Thomas. How are you?
Hi,
Hi, everyone. So yes, I was able to take a look at the report. So the report actually says viral load suppression for 89%. When I usually like I also like the cross collaborative, the last phase report. That one said 89.7, so it looks pretty close. So when I drill down on it, there's 11 patients that are not virally suppressed. 5 of them are pretty new patients, and this is back from the beginning of the period, so from March to now. 5 of them are new, so we're working with them. They came in not virally suppressed for the most part. 3 of them are still consistent. We haven't seen them in quite some time, but we are trying to, you know, get them back into care, but we're not able to locate them. 2 of them we're actively working with them. 1 of them we're working with the family as well to try to see what things we can do to make sure that they're compliant with their meds. And 1 is having labs next week. He had been out of care for a little bit, so we're expecting that he'll be back virally suppressed when we get his lab results that he's going to do next week. So that's basically my project too.
Okay, really good update. You know, and again, I think it lends itself to making sure that we know our clients and we know who they are and who we really need to do some intensive work with. And it sounds like you are definitely on the right path. So Priscilla, we appreciate all the hard work you're doing at St. Mary's.
Thank you.
All right, straight and narrow, Miss Gloria, Miss Connie.
So I just learned something new. I didn't know about the bread number. But I think I kind of knew who my deficient, like my clients that are not virally suppressed. Like I already knew without clicking on it, but I did it anyway just now. So for the month of August, we were at 81%. In September, 82%. And then I did it for just for the 10 days in October, without at 100% for the month of October, the 10 days in October. But I do my number for clients that are not virally suppressed. I've definitely identified them. They're always been my problematic clients are trying to make sure that they're keeping their doctor's appointment. That's the biggest thing. But I do, I have a few clients that are like with private providers. So this is the other thing that I did find out during this time, like running this report, is that even though they go to a private doctor, as long as the client is aware that they need to be telling the doctor, I need to get this blood work done every 3 months, every 3 to 6 months, that's working. It's working because it's really, I'm learning that I need to really make sure that I'm empowering them to make them understand that you need to see these numbers so you can understand what's going on, and having a little some improvement with engaging the client. If you want to go to this private doctor, you don't want to go to a clinic anymore, that's fine. what I do need to keep up with this. I hope to keep up with it. So that's working. That's working a lot.
That's awesome. And so I think something that we've been talking about doing maybe in the next year is asking our case management providers to really identify those private facilities that our clients are going to. And then we will be able to take those provider names and give them to the AETC. And then our AIDS education training centers can reach out to those private providers and provide some continuing education units for our CMEs to those private providers so that they understand what the requirements are for public health service standards to make sure that they're meeting those. And so one of those would be, getting your labs done every 6 months or so often to make sure they're meeting those as well. So we'll be doing that as well.
Yeah, you know what? I'm gonna just say this. Like a few years ago, I had a client that he was with a private doctor, and he had been with the clinic, like St. Joe's before, but of course he was kind of running from wanting to not be seen or whatever. So when I talked to the doctor, I found it pretty interesting that the doctor, he was like, oh no, I didn't know. And he said, yeah, I should be doing those things for him. And he started doing it. So, I mean, if it helps, I could provide like with a list of doctors that I've used. Just a lot of them popping up, which is really a good thing.
Yep.
So, yeah.
And that's a great opportunity too for the providers to receive those continuing medical units, which are, kind of hard to find sometimes. And the AETC would absolutely, love the opportunity to provide those because, like our legislative requirement is getting people to viral suppression. Their legislative requirement is for educating those who are not aware of the HIV standard. So that would help them out tremendously as well in making that contact. So some great input, Gloria. We appreciate that. Ms. Connie, anything from you, ma'am?
I just wanted to say, like, I have like 10 clients that I meet regularly, do individual sessions with. I have random urines, and they're all consistent. They're doing what they need to do. However, there's some, like I have one that, is a little struggling a little bit, but they're trying to do what it is they need to do, and I'm helping out as much as I can, because again, you can offer the services, but you can't make a person want them. So it's a lot of people here, but I meet with consistently like 10 to 11 consistently every week. So everything's good.
Great. Thank you. We appreciate all the hard work you're doing as well. Thank you.
May I ask a question, Thomas?
Yes.
The ATEC was speaking of, when are you going to be asking for the list of private physicians? Because
I'm going to reach out to the AETC first to make sure that I don't bombard them and give them a list of 100 providers and like, what are you doing? So I want to work with them first with Michelle to kind of outline a strategic plan of how we can get them the opportunities.
Right.
But it's going to be in the next year. It's not going to be in the next 6 months. It's probably going to be 6 months plus.
Because there's a few of my primary care physicians that, when the client goes to ask for those documents or to, even when we see them release the information for, are very stubborn when it comes to that.
Yes, ma'am.
And I even have one because we asked for the medical piece. They even began to start charging their clients $25. I'm serious.
Yeah, that's crazy.
$25 for one sheet of paper.
Yeah,
So maybe that can help them as well see the services that they would be providing for their patients.
Agreed. And maybe the AETC can tell them some of the legal ramifications of how they can't charge for those laboratories.
Oh, but they do.
I know. I hear you. All right. Thank you, Ms. Tisa, for that as well.
Okay.
And I see that we have Ms. Paula join us. We're going to put you on the spot, Ms. Paula, if you would like to introduce yourself and then let us know if you were able to run your care continuum dashboard. And if so, what were your results this month?
Thanks, sorry. Are you guys able to hear me this time?
Yes, ma'am.
Perfect. So I supervise the HIV services at Brigham Family Center. We do mental health, early intervention, and outreach. So Thomas, I ran my report support just mental health and EIS because some of the outreach we were doing in a different way. So when I did that, I went from 69% to 75%.
That's awesome.
Yeah. Last month, when I run it that way, we were pretty much at 75%, but when I look at like mental health services, there's only one client that's not virally suppressed, but he's brand new to us.
Okay,
We're just,
great.
he's also new in EIS.
Okay,
So
great.
the ones that, you know, I've been looking at to see who's not virally suppressed, they're pretty much all brand new, either diagnoses or out of care that we just
Okay.
started working with.
And Ms. Paula, I think you brought up a really good point. So if you are an organization who may be funded for multiple services, right? And you want to be able to break your care continuum dashboard down by that particular service, you would just simply go into services, take off the all service category. We're here instead of selecting all, and you could look at it. So if you wanted to see it by clinical case management, and then maybe you could give it to each of your particular departments to really work on it, and not a siloed basis, but in a more specific base of saying, okay, now in our medical case management, you know, we have this rate, in our EIS department, we have this rate, and it would really help, you know, kind of pinpoint those particular clients within each of those services to really work on that viral suppression rate. So that's a really good point, Paul. I'm glad you brought that up. So you can either run it by all services by selecting all, or you can pinpoint it down to case management, clinical case management, you know, psychosocial support groups, etc. All right, great point. Thank you, Paula. All right, I think we hit everybody there on the care continuum dashboard. So it's great news to hear that each time we talk about this, someone is learning something a little more about that care continuum dashboard. So yes, those red numbers are kind of your best friend. They'll kind of identify those clients who aren't meeting that particular threshold or performance measure along your care continuum dashboard. So please utilize those and look at those on a regular basis. That will also help you in getting that data in and making sure. Again, if like Tisa, you come across a client who's you look at and say, well, you know what? No, I see their data in there, but for some reason it's not being counted in this number. Simply shoot Millie and myself that client's E2 ID, and you know, give us a little blurb like, hey, their medical outcomes are in there. We're not sure why it's not counting, and then we can get a little more clarification. Or there may be a glitch, and we can fix the glitch on the back side to make, who knows, everybody gets a 10% increase next month because we caught a glitch, right? So low-hanging fruit. All right. Any other questions about the care continuum dashboard? Again, we appreciate all the hard work you're doing and looking at that and tracking that. So we appreciate that. Thank you. Keep up the hard work. It will definitely pay off in the outrun. All right, next we'll talk about clinical quality improvement projects. So you should be tracking those on a monthly basis and in your worksheets, and logging that into your worksheet so you can keep track of that. We won't go into great detail. I know some of you may have been taking a little bit of a break this month, or may have been out of the office for a couple of weeks, either spending time with my staff doing monitoring and USCA and types of conferences that happened in September and October. Anybody want to speak particularly about their project or report out on that? If not, we can come back to this next month and we'll report out for both October and November. But if anybody would like to give themselves a shout out for the hard work they have been doing and want to report out on one of their clinical quality improvement projects, please, now is your chance to give yourselves kudos. Anyone? All right, no problem. All right, next, again, we'll talk about, and we made this announcement during the recipients report, we'll talk about sub-recipient monitoring. The site visits for programmatic chart reviews, again, is complete. Now your next step is to have all the fiscal and universal monitoring uploads to the FTP site no later than Friday, October the 21st. And then 30 days past that date, you'll have a final monitoring report. Just some brief high-level things that I can speak about from what I saw during the monitoring, and my colleagues Derek and Mikey noticed during monitoring, is that we do have a lot of work to do. We do need to do some service delivery models and talk about how to efficiently provide services to our clients and track those services. And I think that's going to help us twofold. One, in our medical indicators and eCompass, so with our viral suppression and our care continuum dashboards, and also making sure that we're streamlining the process. We want you to work smarter, not harder. So Millie and I are also working, and my staff are working on the back end with some ideas of how to help you chart better and more efficiently, and that you're not digging through 4 folders or volume 7 of Thomas's folder, right? Because I did see some organizations who had multiple volumes of a client file. So what we definitely want to do is assist you in the process of working smarter, and not having to go through all of that. I will say that there is one tidbit of information we can give you. You may see a new eligibility module starting out in March 1st for the new grant year that I think will assist all of our subrecipients in ensuring that clients are Ryan White eligible. So we are excited about that. You'll hear some more about that as we get closer, and some training opportunities as well. And then we're also really looking forward to the EIS program model and combining that, EIS and outreach together into one model and efficiently providing EIS services. So I think there'll be some opportunity as well for those clients who are not linked to medical care or that were lost to care to be referred to an EIS program where those EIS workers can find those clients and ensure that they are linked to medical care, right? That's our main goal, is making sure our clients stay linked to medical care. All right. Any questions about subrecipient monitoring thus far? I know it was a heavy lift this year. I know it's a whole different process that we were used to. I will tell you from just our experience of doing this, it is a very insightful process that allows us to see, really how we are documenting and making sure that services are continued across the entire care continuum and they look the same. So making sure the clients are receiving really good services. All right. All right, next we'll look at the data presentation from our care continuum dashboard. And I ran these numbers very quickly out of the care continuum dashboard. And this is aggregate. So this is for the entire TGA. So when we look at July in our care continuum dashboard, we're at roughly 82% viral suppression, went down in August to 79%, and back up in September to 81%, right? And we know that fluctuation can be a couple of different things. One, we have some newly diagnosed individuals who are not virally suppressed. Two, we're returning people who have been lost to care and not linked to medical care back to care. And again, those people also could not be virally suppressed, or it's just new people coming into our area, right? And we're linking them to care and getting them linked to services. Also, when we look at that from the entire time instead of just monthly, when we look at it from 3/1 to yesterday, we're at overall a 73% viral suppression rate. Okay, not bad. We definitely want to be in the 90s, but again, we know this is a work in progress. And I think some of this is a data issue that we just need to identify those clients we know have those medical indicators in there, and then clean those up to make sure that they're being counted in that number. So again, you identifying those in your care continuum dashboard and reporting those back to Millie and I will definitely help us in relieving some of that missing data. All right, and then we broke it down in a couple of different demographics. So when we look at it in gender, we have male, female, transgender, and unknown. And so you can look at that across the board graphically. And then when we look at, oh, I forgot to put that one in there. My apologies. I meant to drop the gender graphic in there for you had the numbers, so I apologize. I may have messed this up completely. So I did not put the graph for race in here, but I did put the table in here. So when we look at viral suppression rates in comparison to race, we see that our American Indian and Alaskan Native of 2 clients, and only one of those are virally suppressed, so it really does drop our viral load suppression rate to 50%. When we look at white, 73%, African American, 71%, Asian, 69%, and other at 88%. So other could also be multiracial. right? Yep, got this all mixed up, y'all. Ethnicity, I got back on cue. So we both have the table and the graph here. When we look at ethnicity, we see that our non-Hispanics are 72%, our Hispanic or Latinos are at 73%, and an unknown is virally suppressed at 100%. Again, overall, our overall rate being 73% from beginning of the grant year to date. When we look at our age breakdowns, so looks like we have a majority of our clients who are 65 and older, or I like to say 65 and better, or 80%, 55 to 64, 76%, 45 to 54, and then we start seeing a little bit of drop-offs in our younger communities, right? Those being from 19 to 35, less than 64% aggregate. Our mode of acquisition, or what we used to say is our method or transmission mode, when we look at those combined, we see MSM at 69%, IDU at 71%, heterosexual contact 76%, blood transfusion or recipient of blood component 78%, mother at risk 67%, or perinatal, and others at 66%. And then we still have some unknown identified, 19 of them, who do not know their mode of transmission or didn't identify a mode of transmission, being at 58%. Subpopulations of focus. Our three subpopulations of focus are our Black, MSM, Latinx, and transgender communities. Again, our underserved population, transgender, is only virally suppressed at 33%. Keep in mind that 3 people have been identified as transgender, and one of those is not currently virally suppressed. So that does bring us down to, what doesn't work out right? 33%. So I'm sorry, 2 of those who identify as transgender are not virally suppressed currently. Our Latinx community is at 73%, and our Black MSM community is at 65%. When we look at viral load suppressions against core medical services, we see that our health insurance premium cost sharing assistance, people who participate in that, are at 90%. Again, outpatient ambulatory 87, oral health 80, EIS 58, mental health 81, medical case management 78, substance use 78, and overall 77. And this is just for core services. And then we look down at the support services. We see non-medical case management at 73, food bank at 86, health education risk reduction 72, medical transportation 85, outreach services 53, psychosocial 89, and other professional services at 48, bringing us for our support services to 71% aggregate. So you're probably asking yourself, like, what is that data going to do to help me, right? So this can help us really align programming based on some multiple demographic areas. So looking at the data and identifying where some of those underscores or our underserved populations are, and really looking at your programming to identify opportunities for those particular demographics to increase efficiencies across the board. And also looking at our services that will help us align to with what services need to be addressed, or a new service delivery model could be used to help increase those efficiencies across the board. And so I think there's a great opportunity coming soon that we'll be able to start working on some of the service delivery models and addressing some of these underscoring areas, especially along our care continuum dashboard. Any questions about that data? All right, what was on our agenda? Let's see here. Oh, it's the same thing. There we go.
Me.
Yes, ma'am.
No, I'm going back to, let me see, where was it? Subpopulations of focus. And when it came down to transgender, I see only 3. Now, I personally have 1, 2, 3, 4, 5 in itself. You know, one who just completed the complete change from male to female.
Okay.
You know, but I'm not seeing none of that here.
So it looks like, Ms. Tisa, system-wide, there's 6 people who identify as transgender. And it looks like 3 of those may not have diagnosis information in the system.
Oh, okay. Okay.
So keep in mind that when you run your care continuum dashboard, you
Mhm.
also can see this data.
Okay.
So just scroll down a little further on
Mhm.
your care continuum dashboard. Let me see if I can pull it up. Yep. So if you scroll down a little further, it will break down into race, ethnicity, age, transmission, core support. Did I skip gender?
Again.
I did. There we go. And gender. So you don't have to scroll down as far as I did. It's it's before race.
It's okay.
So for this particular organization, you can see who is enrolled or who is identified as a specific gender. And if by chance they're missing diagnosis information, it will be here in red.
Okay.
All right. And if I'm correct, if it's missing here, it's probably not counted further down. Okay. So we got to make sure that these numbers are also specifically diagnosed should be zeros.
Okay.
In the red area to make sure that there's a diagnosis in the system. Again, I'm hoping that the rollout of the new eligibility system will help curb that completely, and that you can't go any further until all that information's in. So I think that's really going to help us in providing services, and that it's going to kind of lock the system out until certain pieces of that information are there. So I think that's going to help with a data concern there.
Because it does say that if everything is not completely filled in, you cannot bill for that particular client. It's saying that now when you're putting in data.
Okay, awesome. It's not even going to let you type anymore.
Oh, stop.
It's going to lock it out completely.
You're cruel.
I know. Cruel world. But I think it's going to help us out data-wise. So when we go back to the system and we really need to pull data and really look at the indicators, it will really help us identify those subpopulations that we really need to be focusing on. Right? All right. And then, great question, Ms. Tisa. Thank you. All right. All right. And so one more announcement that I did not put on the agenda that I forgot about, and we'll talk about this next month, but I kind of want to give you a preview. And this is more for our outpatient ambulatory health service providers. Please keep in mind that the MMR report or MMWR report from the Centers for Disease Control and Prevention has recently updated their guidelines for the zoster vaccination, or the recombinant zoster vaccination, RZV. If that sounds like it's foreign or alien to you, it's for outpatient ambulatory providers, so it may be. So keeping in mind that now the new protocol, it used to be 50 and older. Now they are suggesting as of October the 20th of 2021, and the recommendations have been accepted, that those clients who are immunocompromised receive the zoster vaccination for ages 19 and older. So they have really lowered that age range for that. So we do recognize that zoster is a hard vaccination to keep on the shelf. However, now if we're doing it for just about all of our population, it might be a little easier to keep on the shelf instead of looking at our aging population, 50 or better. So I think this might help us out in being able to keep this vaccination on the shelf medically.
Or in the refrigerator.
Yes, ma'am. Yeah, don't keep it on the shelf. You're exactly right. Don't listen to me. Follow the guidelines.
Hey, Thomas, can we get those immunizations put into E2 because they're not in E2?
Yes, ma'am. Priscilla, if you will shoot us
sure,
an email. Again, Millie and I are also working on the sub-service breakdowns as well. There's going to be some changes in service units coming very soon to some service categories to help better capture what we call productivity reports, right? So currently one of the things is medical case management. It's at 30 minutes for one unit. If you call 16 clients today, it technically looks like you did an 8-hour day, right? And it probably only took you 30 minutes. So we're looking at some additional ways to capture that and to give our medical case management subrecipients an opportunity to really capture what they're doing, and not asking people to not bill for certain things or not go over a certain number of hours. So we are aware of that, and we are working on that. Again, some great data that came out of the monitoring visits and some opportunities that Millie joined our staff in looking at that and trying to come up with innovative ways. So we will be working on that hopefully to kick off before March 1st. So we're excited about that and some training opportunities.
Thomas, I'm sorry, can you give me the two that you had just mentioned, that it was the shingles and
Oh, just the zoster.
just a zoster? Okay,
Yes, ma'am.
all right. And that age you said dropped for immunocompromised.
Correct. Yep. I'll
Okay.
send. I'll drop this report into the chat.
Oh, great, okay.
Yep. And so over the next year, let's see, it's this one. Let me. If it lets me. If not, Priscilla, I will email it to you. Oh,
Thank you.
you're
I
welcome.
could probably look it up too, but
No
if you have
worries.
it, that's easier.
There we go. All right. Should file and send. All right. Hopefully you can see it in the chat now. Everyone should be able to. There it is. All right.
Yes, thank you.
You're welcome. And so, we'll be working on that as well. Over the next year or so, it will probably be, you already noticed if you were outpatient ambulatory, we baselined it this year for those who are 50 and better. Next year, we'll probably lower that down to the 19 and better and just baseline that to get an idea of, what's happening system-wide and if there are any types of barriers to being able to do that. Again, some of those are when you're talking about only vaccinating our clients who are 50 and better, it's hard to keep those types of vaccinations valid within their date ranges and keeping those in the refrigerator for use, right? Because it's just a hard thing to do. It's,
So Thomas, I'm so sorry to bother you again.
Yes, ma'am.
So I did get the shingles that you just did, but when we were doing the evaluation, it looked like also tetanus, shingles, MMR, HPV, and those are not listed in the immunizations on E2. Those, some of them are really hard to get because they're from old records and a lot of them don't have records from their other countries. But we did note a few had that information, so we did put it in our logs, but there's nowhere to put that in E2 as well. But I just wanted to bring up the fact that some of these, especially if they're things that are done when they're a little younger, they may not have their records.
Sure. And then keep in mind for that medically, we can always run the titers.
Yeah, or just most of them have to be revaccinated anyway. So we just usually will revaccinate.
That works too. Yes, ma'am.
If we don't have a record and we know
Right.
that it's probably been a certain
More than-
length of time. Yeah.
And then
Yeah,
also,
more than 10 years for tetanus. Okay.
yes, yep, the TDAP or TD.
Yeah.
And then also keep in mind that these are just suggested requirements, and I can't stress this enough. The medical provider is the medical authority there. If the medical provider decides it is not medically indicated or medically necessary, just simply document that in a note to say, hi, me, Thomas, the doctor says, I don't feel like my client needs that, or at this time it's not. Yep. So it's not like
All
you
right.
have to, it just needs to be documented that the provider does not find it medically necessary or medically indicated at this time.
Oh, okay. All right.
Or declinations, also document declinations. So
Yes.
not everybody wants the flu vaccine, but you also don't get credit if you don't document the declination of it.
Exactly. Yeah, we have those, but for these, this was the first time in a review that these particular ones came up. So we just happen to have complete records for a handful of them, but a lot of them we don't get those records. So I have it on my list for them to start looking into that a little bit more.
Okay.
But the doctor was concerned, about having to give each one of those because a lot of them we don't have available here. But we could always, some of the pharmacies, local pharmacies do have those available so that they get them if we can't.
Yep, that sounds good. Or maybe we
Shingles
can
is going to be the hardest, but we can work on that, especially.
We might even be able to coordinate a vaccination clinic at some point for our client.
The pharmacies do have shingles.
They do.
Yes, the outside pharmacies, right. And we're going to try to see if we can get our pharmacy to provide that as well. So we have a new pharmacy here. So we'll look into that. Okay.
Sounds good.
Thank you.
All right. You're welcome. And then I think Ms. Donna and Irene left, but I was trying to get there before noon, but we're almost there. And then the final takeaway for today is we will see you again on Tuesday, November the 8th. So please, before then, look at your quality improvement projects and also look at your care continuum dashboard. I'm hoping to hear some more increases in those care continuum dashboards. However, I do know that around the holidays, those clients we typically don't see, but maybe once a year, once every 2 years, do resurface. So I am very much aware that some of those viral load suppression rates might actually go down around the holidays because people are coming back into care. But still, you know, it helps us align our views and our service delivery on those clients who are not virally suppressed and help us increase those efficiencies. All right.
And remember, Tuesday, November 8th is election day.
I have the darndest time, right?
Don't forget to vote.
Please vote. I just did my absentee ballot today.
Oh, good.
Let's always do absentee just to make sure I get it in there. All right. Any questions before I leave you for today?
Thomas, I have a question.
Yes, ma'am.
When we get the email from you, I don't know if it's coming from you or Derek. I think it's Derek, like it gives us the list of the meetings that's coming up for the month. Why is CQM not on that list?
Yep. So Derek does all the planning council side and I do the CQM side.
All right.
I don't want to confuse everybody.
So I'm sorry, when is the next? Oh, November 8th. And
Yes, ma'am.
so we're not having planning council that day. No, because we would have it November 1st. Never mind.
Yes, ma'am. That's correct. Woo, we made it this year. It was the first last year would have been on the Wednesday, I think. So perfect. All right. All right. Any other questions? All right. Again, on behalf of the recipient's office, we want to send all of our gracious and appreciation on you completing all of your CQM projects and participating in this. We hope that everybody's starting to get the hang of CQM. I will say that coming very soon, we will start kicking off subrecipient meetings. So going into next grant year, I don't think CQM needs to meet as often. So probably beginning March 1st, we'll meet every other month, and those in between months will more than likely be subrecipient meetings so that we can talk about service delivery and we can kind of key about how we want to do, what we want service delivery to look like in our TGA and how we can get to over 90% viral suppression rates in the next year, right? So we're hoping to be able to back down a little bit and give some more opportunity for technical assistance as we move forward into the next grant year. All right, if there are no other questions, I appreciate you again participating today, and we will see you very soon. Thank you and have a great rest of your week.
Well, have a blessed day.
Everyone have a blessed week.
You too. Thank you.
Bye.
Thank you.
Bye.
Nice